Welcome once again into the Radiopedia, Reading Room, a podcast unconcerned with books or poetry, tea leaves or palmistry. This is a radiology podcast. My name is Andrew Dixon, and joining me, he's the sis to my fiesta. It's my co-host Frank Gaylard.
Oh, you say cis too, but shouldn't we be saying kiss because it's constructive interference in steady state? Or is this a GIF versus GIF thing?
I've always said cis, but I've listening to the main segment for today's podcast before. I noticed that Daniel Gewolb and Francis Deng definitely say kiss. So
Yes.
maybe we should switch to that.
I think I'll have to.
But I definitely go the hard G for GIF. GIF.
Yes,
Sounds
obviously
good.
it's GIF, it's not GIF, just because it stands for graphics interchange format. But I think inexplicably, the person who created GIFs pronounced it GIF. That's where the confusion comes from. I don't know.
It's just trolling everybody on an ultimate level, isn't it? You come up with the actual name, graphics interchange
And
format, and then you're like,
mispronounce it.
oh yeah, but we're going to call it GIF.
Yes, actually, I have some news. The R in Radiopedia is silent.
It's silent.
It's actually Adiopedia.
So maybe we should go with kiss. You're the kiss to my fiesta, Gaylard. Sounds saucy. You're the B0 to my B1000.
Very good.
So speaking of MRI sequences, today's main segment, Gaylard, is all about skull-base MRI protocols. So this was recorded at Radiopedia 2025 with Daniel Gewolb, Jennifer Gillespie, and Francis Deng, and they're going to be guiding us through a series of 5 different skull-base imaging scenarios and how they'd approach each. But before we jump into that, 2 things, Gaylard.
Mm-hmm.
The first is that my wife has had an ankle reconstruction, and she needs to have her leg up in the air apparently 23 hours a day for the next 2 weeks, which basically means she's in bed or on the couch. And so I need to let people know that she and my son in the very next room are playing, and Ali told me this, Trine 5 on PlayStation 5, and it's a co-op puzzle platformer. And apparently you cannot play that without talking to each other. So if you hear voices in the background, that's my excuse today. The other thing is, you would think that somebody who's got their leg up in the air 23 hours a day, you would think there's not going to be much shopping going on, things like that. Sure, I'm going out doing all the shopping for food and stuff, but I have never seen so many box deliveries coming to the house, Gaylord. My son took a photo yesterday of my wife on the couch with the leg up, just surrounded by boxes that have been delivered during the day.
And this is for a month, is it, Dixon?
It's going to be a month.
And you're going to have to pull some extra shifts at the work.
I've taken to actually sitting there and watching a TV series with her to try and reduce the amount of time she's on her phone or computer so that she can order less things. So anyway, if you hear voices, that's them playing a game in the next room. And if you hear the doorbell, that'll be another bloody delivery that I have to go and traipse down the corridor to my wife. And the second thing I needed to mention here is that you've been skiing, Gaylard. How was that?
Oh, yes. I went with my family on a very quick sort of 7-day skiing holiday to Japan. And we've been a number of times before, but this time we did a little bit differently in that we landed in Tokyo and we hired a car with snow tires, and then we drove up to Myoko, which, amazingly enough, I think there are more Japanese people per capita here in Melbourne than in Myoko, because it was entirely filled with Australians, which was in some ways a little bit sad. But the thing that's cool about Myoko is that it's a little town that, unlike Australian or most North American ski resorts or European ones to that degree, where you stay on the resort, here the town is just a town. And about half an hour from the town, there are 5 or 6 different small resorts where you just drive up and park your car like if it was a shopping centre, buy your ticket, and then ski. And they've only got a handful of lifts rather than a really big terrain. It was lovely. It was really good. We spent a day in Tokyo on our way back, drove in the snow, didn't crash, didn't break anything, no injuries. So overall,
did you get a lot of powder skiing?
Not a huge amount, but enough. One night, about 3 days in, I think, it snowed about 20 centimetres overnight. And so the next day was fun, but it was really cloudy and visibility was terrible, like you were in the middle of a cloud. And so we skied some trees and during the day. And then towards the end of the day, like around maybe 2:30 p.m. or so, just when we were thinking of heading home, when we were on the lift back to the summit, miraculously the skies opened up, blue sun, No, the sun was the same color as normal, but the sky was blue. And off to the right, just as the ski lift was going up and I was sitting there with my sons, there was this bowl of completely untouched powder that had been sitting there all day because no one had found it because it was so cloudy. And so we rushed over there, but we got there and they were cordoned off as an out of piste.
Oh, yeah.
Now, this is a public service announcement. Avalanches are a real thing. They should not be taken lightly, and you should not ski off-piste if it's dangerous. But this thing was like 10 to 15 degrees slope, just this beautiful field of powder next to a green run. And my son, my oldest, who's very well behaved, was like, "Dad, no, you can't." And I'm like, yeah, you can. So I just jumped under the ropes.
Yeah.
And I skied over maybe 200 or 300 meters of perfect snow, like the kind of snow that you see in heli skiing ads, just completely untouched. And you get into that beautiful bouncing group. It was amazing. And then I skied back onto the piste under the rope, and I was accosted by a ski patroller. And my sons kind of had skied down on the run and were sort of 10 meters away. And they had to watch as this very polite young Japanese man confiscated my ski lift ticket.
You're gone.
And my youngest thought it was awesome. My eldest was so distraught, so disappointed that his father would do this. He wouldn't speak to me for half an hour. And made worse by the fact that then without a ticket, I still snuck through the queue at the ski lift and just went next to the barriers to get back on. And we had to head home, so otherwise we would have had to walk. So I set a terrible example.
Well, I agree with your son there, Gaylord. That was very naughty of you, and I've always thought of you as quite a good boy generally.
Yes, I am a good boy, but I'm not lawful. Do you know the Dungeons and Dragons character alignment matrix?
No, never heard of that.
Really? That surprises me.
Would you expect it?
Anyway, in D&D, characters have this sort of two axes alignment matrix where on one axis you are good, neutral, or evil.
Oh, yeah.
And orthogonal to that, you are lawful, neutral, or chaotic. And my eldest son is definitely lawful good. He likes his rules. And so jumping under a rope, whether there is a good reason for it or not, that's not on. My youngest son is probably neutral, or maybe neutral chaotic. And I think I'm pretty much neutral good. I've never really had a thing for rules.
Yeah.
Like, I like the consequences, but a rule for the sake of a rule has never really appealed to me. And there's a part of me that's a little bit chaotic because I quite like breaking rules that are dumb for the sake of breaking them.
Actually, I like this axis thing. I reckon this is better than all of the personality tests that are out there. I reckon just like, where do you align on those two things?
Yes.
Probably more descriptive than the other ones.
Oh, hey, in a future episode, we should do one of those Myers-Briggs personality tests.
Do you reckon it changes over the years?
I've done it a bunch of times over the past 10 or something, and I've always scored the same thing. I think they're pretty good.
Yeah, well, maybe we can do that. Sounds like a good idea. But we better get into the main segment here, Gaylord. Yes. So this appeared in a session where Francis had just given a lecture on neurovascular compression syndromes, Jen a lecture on pituitary region, and Dan a case set on pulsatile tinnitus. You can find all these gems over on the Radiopedia lecture collection and our case reads collection. That's if you're an all-access pass holder. But for now, let's listen in to this case-based scenario, and then Frank and I will be back for another chat in the outro.
Hi, I'm now joined by Francis Deng and Jennifer Gillespie to discuss skull-based MRI protocols. Welcome to you both.
Great to be here, Dan.
Hi, Dan. Hi, Francis.
So during this section so far, we've each presented different topics that involve the skull-based region, which all require different MRI imaging protocols to optimize them. So my plan for this discussion today is to pose 5 different clinical request scenarios and for the two of you to assist me in explaining what kinds of sequences and planes should be performed for each and why. For scenario 1, we have a 56-year-old male with progressive left trigeminal neuralgia, no history of multiple sclerosis, evaluated for neurovascular compression or mass. I guess we can start with Francis here if you want to just kind of pick some kind of key sequences and maybe some teaching points that can go ahead and complement your talk.
Yeah, absolutely. Thank you, Dan. So when thinking about neurovascular compression syndromes, probably the workhorse sequence that we go to is a high resolution, i.e. 3D heavily T2 weighted sequence. And this is useful because we're looking for vessels that are compressing the cranial nerves within the cisternal segments. And the heavily T2 weighted sequence is a cisternographic sequence that highlights well the cranial nerves as they're coursing through the cisterns and anything that is bumping into their path. So the workhorse is going to be what I would consider heavily T2 weighted, and depending on your vendor, that may have different acronyms. Here, we're a Siemens shop, we use a KISS sequence, which is constructive interference in the steady state. If you use a GE scanner, it might be called Fiesta or Fiesta C. If you use Philips, it would be Balanced Fast Field Echo or BFFE, and so on and so forth. And we do that pre-contrast, and it's important to think about whether you're doing that pre or post-contrast, because even though it's traditionally thought of as T2 weighted, it does have some T1 weighting as well. So if you give contrast before a KISS sequence, things that light up with contrast are going to be brighter as well. And and that may or may not be intentional. You use it for different effect. But if you give contrast and then do a KISS sequence, then the veins will be higher signal and kind of blur into the CSF at times. So you just have to be aware of that. So we do our KISS sequence pre-contrast, and I use the KISS sequence, to look for anything bumping to the trigeminal nerves. In addition to that, I then do a non-contrast MR angiogram, the time of flight angiogram. And this is good because it highlights well the arteries in the region. And recently I've been fusing the time of flight angiogram with the KISS sequence. And so you can kind of color code the arteries red, overlaid with your KISS sequence, and it shows quite well the arteries that are conflicting with the trigeminal nerve. And then the final key sequence I would say is helpful in most situations is a T1 post-contrast sequence done with the 3D technique. We use 3D Vibe with fat suppression, but you can use MP-RAGE just as well. And we do this because you'll have vascular structures conflicting with your trigeminal nerve that are not arteries, that are veins, and these will show up quite well as contrast enhancing. So if you're ever wondering, what is that vascular structure that is contacting the trigeminal nerve, I don't see time of flight related, flow related enhancement to suggest that it's an artery. I can be very confident it's a vein if I show that it's contrast enhancing. So those are the workhorse sequences that you need to make sure is part of your trigeminal neuralgia evaluation protocol, which is, a KISS or Fiesta sequence that's heavily T2 weighted, a time of flight angiogram to highlight the arteries, and a post-contrast T1 high resolution sequence to show veins in the area. And then finally, because there are secondary causes of trigeminal neuralgia, we need to ensure we have a sequence that's well suited to identify secondary causes like a tumor at the skull base. So, the T1 post-contrast sequence doubles for that purpose. We can see quite well enhancing lesion in the skull base, affecting the sphenoid body or affecting the foramina from which the trigeminal nerve emerges. And we just have to make sure our field of view for both acquisition and for our, visual review includes that region kind of at the skull base and extending anteriorly into the face.
I guess just to summarize then, so some of the key sequences you mentioned, the thin slice heavily T2 weighted, depending on the vendor, it could be KISS or Fiesta, and then now it's going to best visualize the cisternal segments like you talked about. Time of flight MRA, mostly for the vascular anatomy. It's also helpful to distinguish, artery from vein. And similarly, the high-res post-contrast T1 also can kind of highlight venous enhancement and be used for like other causes of like more trigeminal neuropathy. For example, if you have like inflammatory etiology, or if there's like a neoplasm, something like that, then the post-contrast can also double for use there, and you can kind of tease that out. But I noticed from your talk as well, it's one of the good teaching points is kind of to focus on the nerve root entry zone of the cisternal segments of the cranial nerves. Most are like basically from the root entry point through the transition zone, which is, kind of what you laid out as the root entry zone. And that's kind of where the vascular compression is most important. And you mentioned specifically too, you're not just looking for like vascular contact, right? You want to also see if there's like displacement, deformation, or atrophy of the nerves, which can kind of be a little bit more specific than if it's just kind of near or touching the nerve itself. And then, of course, at the end of the day, we want to rule out other causes of trigeminal neuropathy in case of like masses or inflammatory lesions as well.
Absolutely.
One thing I was going to make a comment about is using the different planes. So both coronal and axial, I find really important for trigeminal neuralgia, just to kind of see that distortion of the nerve that you might not appreciate in the axial plane, and then you put it in coronal and you can see that it's being, squished off to the side.
Oh, absolutely. I like the coronal best for that as well. Sometimes the axial can be very tough, but if it's like superior, inferior displaced, something like that, the coronal can be very helpful.
Yeah, absolutely. And we do ask our technologists to make multiplanar reformations as well. But in the packs that we have, it's very easy to make your own custom multiplanar reformations kind of at will and allow you to cross-reference every structure you're kind of looking at. So definitely very helpful. So I use both axial and coronal when reviewing these studies. Absolutely.
So I guess we can move on to scenario 2. So we have a 72-year-old diabetic female with persistent notalgia and cranial nerve 9 and 10 palsy, evaluated for skull-based osteomyelitis. I guess, Jennifer, do you want to take the lead on this one?
Obviously, your T1 pre-contrast is going to be really important in this case, looking for that kind of marrow infiltration that we would expect with an osteomyelitis, and then your post-contrast T1 as well. T2 FATSAT, I find, or STIR, is particularly helpful looking for the sort of that edema within the bone marrow, and also looking below the skull base, the infratemporal fossa around the nasopharynx, the soft tissues below the ear, and that sort of thing, trying to assess for collections. Which also, both the T2 and the T1 post-contrast are really important to try and find if you can see a little collection that needs to be drained, and really to alert the surgeons as to the areas that you're most suspicious about when they go in and try and biopsy and confirm that it is actually skull-based osteomyelitis.
Do you ever use I've seen some in the literature about like DWI-ADC. Of course, it's great for abscesses or if there's like intracranial complications, if you have intracranial abscesses or maybe strokes as a complication of meningitis, something like that. But they also talk a little bit about how the ADC values can be useful for distinguishing, because the main differential would be like nasopharyngeal carcinoma, for example. So they can talk about how ADC values can be somewhat useful for distinguishing like infection from neoplasm. Do you have any other tips to kind of help distinguish, let's say, tumor from skull-based osteomyelitis?
Often it's really hard. Sometimes it's just a little kind of feeling that you get. Obviously, the clinical history is really important, and how long they've had symptoms for. I find that with the skull-based osteomyelitis, often it's just a little bit fuzzy around. The fat planes it looks inflammatory versus a tumor and more mass-like. Lymph nodes are often quite helpful in that if you've got a big, large nasopharyngeal malignancy, you're often going to expect to have some really nasty lymph nodes associated with it, not just kind of reactive nodes.
Definitely.
Yeah, sometimes it's really hard to tell the difference.
Yeah, that's why they often end up going to biopsy. But I was just wondering if you had any other tips. But I mean, I like that. I think for me personally too, like similar to what you said, if it's obviously mass-like and the actual local architecture is distorted versus if it's kind of maintained and there's more just like infiltration of the anatomy and stuff like that, that tends to lean more to an osteomyelitis. And then also I guess if there's like, a lot of these tend to be otogenic in origin. So if there's like, external auditory canal involvement or something like TMJ, something out more laterally, that might be helpful as well.
Yeah, definitely. Yeah.
Well, I guess I can just summarize then first. So from the key sequences, T1 pre-contrast is great for looking for the inflammatory infiltration, particularly of those fat planes and the skull base that are going to get kind of infiltrated, as well as the marrow. Like you discussed is that in your talk as well, how the T1 pre-contrast can be very useful for marrow infiltration. And then the STIR or T2 FATSAT, as well as the T1 post-contrast, really great for edema in the marrow, as well as the soft tissues below, and really can help localize collections. Somewhat similarly, DWI-ADC can also be used to kind of localize those collections, determine if something's actually an abscess. And then I also like it for kind of like intracranial complications, both the T1 pre as well as the DWI, if you're thinking about maybe complication of like meningitis or something like that, or intracranial abscess. And then of course, sometimes you can use like a CT as an adjunctive as well, just in case, if you're looking for like erosions or something like that, or sclerosis. And also, like I mentioned, how a lot of these tend to be otogenic in origin. So sometimes a CT temporal bone showing those kind of like erosions of the external auditory canal or, the glenoid fossa, something like that, can be pretty useful, as well as kind of helping determine increase your specificity.
Yeah, Dan, on that point, I had a mentor who was an abdominal radiologist in residency who would say that, what's my favorite sequence on MRI? It's actually the CT. And there are certain situations, disease processes, that I think CT quite well highlights changes that may be quite less obvious on MRI. And when it comes to skull-based osteomyelitis, I think early bone erosion, that's certainly the case. When it's otogenic skull-based osteomyelitis, the first places that you'll see changes might be the parts of the temporal bone that don't have a lot of marrow. So like the tympanic plate along the external auditory canal. So when we're talking about necrotizing otitis externa, like the lateral part of the bony EAC is going to erode first. And you're not going to see marrow changes on MRI at that point because there's not much marrow to speak of in that part of the bone. So it's like very helpful to identify bone erosion on CT because that may be the earliest change that clues you into this is necrotizing otitis externa, not plain old otitis externa.
And I think with everything in the skull base, CT and MRI, really, you kind of need both of them together a lot of the times with anything skull base related.
Any other questions, comments, I guess, or we can move on to scenario 3.
Well, I guess I had a question for both of y'all is, what modality do you like to use if you were asked by one of your ENT surgeons, what should I get for follow-up imaging for this patient who has skull-based osteomyelitis and they've been on several weeks of antibiotics already? What should we be looking at in terms of monitoring for disease progression or treatment response?
I think that's really hard again. So in my experience, a lot of the changes with skull-based osteomyelitis stay around for weeks, months after treatment. And the patient might be clinically doing really well, but the MR still looks terrible. So I find I have to kind of tell my clinicians that, just because it still looks bad, as if the patient's doing well, it's probably heading in the right direction. So we often don't try not to image them too quickly unless they've deteriorated. So if they're, developing new cranial neuropathy or worsening neurology, then we obviously would go and do an MR looking for those complications like the sinus thrombosis and, meningitis and collections. But I find the imaging lags behind the clinical response. I don't know what you guys do.
Yeah, I mean, that's a great answer. I think for me, I don't have any specific recommendation, but what I would probably say is like you said, if the patient is doing better clinically and these changes can persist for a long time, I wouldn't rush to image. But if I was going to pick something, it would probably come down to whatever the original baseline was. So if they got an MRI first or CT and whatever I kind of saw the findings best on, I would probably use that for the follow-up. But at the end of the day, because these imaging findings can last for so long, it's probably going to be important to just kind of correlate with the exam and maybe ESR, CRP, something like that. If there is any leukocytosis, any other objective signs of persistent or worsening infection, something like that, before I went to re-image.
Yeah, I'll tell you about a case that I recently came across that is fresh in my mind. And so this is a patient with skull-based osteomyelitis, and they were treated with a good course of IV antibiotics. And at the end of the therapy, they had a repeat CT that showed that there were some subtle progressions of bone erosion at the skull base compared to the kind of intermediate or pre-treatment course CT. And I said, well, that may just be, as you guys are saying, that the imaging may lag behind clinical improvement. But to be on the conservative side, knowing that skull-based osteomyelitis can be kind of an indolent disease that just persists and kind of festers there before presenting again. And I said, why don't we repeat a CT in another month or so, just to make sure that bone erosion doesn't continue to progress, because if it continues to progress, then I would be a little bit more worried. And sure enough, they repeated it. It was actually a month and a half later. There's progression of bone erosion. Now on the endocranial side, there's definite progression of bone erosion on the dorsal surface of the clivus and the petrous apex and so forth, and crossing to the contralateral side. So I was really glad in that situation that we got repeat imaging, because it suggested that their IV antibiotic therapy had not completely eradicated their disease, even though this patient was doing well clinically from a cranial nerve standpoint and pain standpoint. And that was enough for the infectious disease clinician to restart them on IV antibiotics in that case.
Absolutely. I mean, that's a great point too, because the range for antibiotic therapy for these patients is super wide, and a lot of them have underlying vascular disease and things like that. And, once it's in the bone, it can be tough to get out. And like you mentioned too, it can be very indolent clinical picture. So I think that's probably, a great learning point. Like you said, if there's any subtle change on follow-up, maybe, get kind of a shorter interval, even if they're doing well clinically. All right. So I guess we can move on to the third scenario. So this is a 45-year-old male with right-sided pulsatile tinnitus and middle ear mass on otoscopy, evaluated for glomus tumor. I guess I could talk a little bit about this one because this is a pulsatile tinnitus case. So the first thing I always do before I'm protocoling any study, I try and dig for the history and physical exam. As a radiologist, I know sometimes this can be very tough, but I like to do my best to either talk to the clinician, check the EMR, or believe it or not, once in a while I do actually call patients to try and get some useful piece of information if I can't get it elsewhere. But the important things you want to look for when you're dealing with pulsatile tinnitus, you want to ask yourself, is this objective or is this subjective pulsatile tinnitus? And what I mean by that is objective pulsatile tinnitus. This is going to be actually heard as a brewery on auscultation of either the neck or like the mastoids, periauricular region, orbit, something like that. It's usually higher pitched as well. So that could be a hint that you're dealing with an arterial cause of pulsatile tinnitus. Since there are many different causes, we like to categorize them as, bony, neoplastic, arterial venous, as the typical one. So if you do have that high pitched objective cause of pulsatile tinnitus, you're thinking more maybe an arterial cause. And on the other side, if you have more of a lower pitched pulsatile tinnitus that's relieved with jugular venous compression or head turning, something like that, then that's a hint that you're probably more likely dealing with a venous cause of pulsatile tinnitus. So you might want to tag on an MRV or something like that in that case. But as with everything else in the skull base, MRI and CT are generally complementary to each other. If you have to pick one, I typically like to start with the MRI, just because there's an overall better pooled sensitivity for detecting causes of pulsatile tinnitus with MRI versus CT. But there are certain situations where I do choose to start with the CT, and that's typically in the setting if they're on otoscopy, if they actually have a mass in the middle ear cavity, or as well if there's conductive hearing loss. In those cases, I do like to start with the temporal bone CT because maybe the patient has otosclerosis, or maybe they do see like a red retrotympanic mass and there's a paraganglioma, or, you know, jugular bulb dehiscence, something like that. In those cases, I do typically start with the CT rather than going MRI first. And if it's more default or I'm going MRI first, like I said, I like to try, if I can, divide it up into arterial and suspected venous causes, and then add on like a time of flight MRA or a time of flight or phase contrast MRV, something like that. CT is also helpful too for a couple of things. Like for example, like sigmoid plate dehiscence, which is one of the more common causes of pulsatile tinnitus, venous causes of pulsatile tinnitus. It's actually seen pretty well on CT, probably best on CT, as well as like superior semicircular canal dehiscence. You can see MRI sometimes, but I think CT is still probably the best for that as well, which could be another cause of pulsatile tinnitus.
Yeah, Dan, just bouncing on that point, I have many of the same thoughts about the complementarity of CT and MRI for pulsatile tinnitus evaluation. At my institution, we tend to have a CT first approach. As you mentioned, there are some findings that are only valuable on CT, and those are the bony dehiscences, right? The sigmoid plate dehiscence, the superior semicircular canal dehiscence, the jugular plate dehiscence, right? You can't get away from doing a CT as part of your evaluation. Even if you did the MRA and MRV by MR, you still need to do a dry temporal bone CT to evaluate for those bony dehiscences, right? So instead, we tend to try to do a CT one-stop shop. We do temporal bone CT, then a CT angiogram of the head, extending halfway down the neck down to get the carotid bifurcation and to ensure there's not a tight stenosis there, as well as a CT venogram of the head, just because it's so common to have a venous etiology to these pulsatile tinnitus cases like transverse sinus stenosis or a sigmoid diverticulum or such. How about you, Jen?
Yeah, we're much the same. I tend to start with the CTA, CTV, as you said. But I think the clinicians seem to be ordering more MRs these days. So they tend to start with an MR. But often then we make sure we do a CT afterwards to see that we're not missing something like a dehiscence or otospongiosis and that sort of thing.
Yeah, absolutely. Usually we do. I definitely agree with you. Even though we often start MRI, particularly depending on what type of cause we're suspecting, CT often ends up getting done anyway. So, a lot of times it's complementary, but maybe, depending on the patient too, of course, if they can't tolerate MRI or something like that, or it's contraindication, it's also relatively higher cost. CT is totally an acceptable option and often has to get done regardless anyway. So I guess in summary, a couple key sequences. So CT temporal bone for sure, looking for kind of those bony dehiscences first, as well as otosclerosis, middle ear cavity masses. MRI skull-based protocol, usually with the addition of time of flight MRA. That's particularly if we're suspecting an arterial cause. And then also if we're suspecting a venous cause, we can get a time of flight or phase contrast MRV. And then other things we can add on. Sometimes people do like a dynamic post-contrast TRIX or ASL. Tricks can be useful because it's more of like time resolved, like a similar to DSA. So you can actually see the early venous filling, and it's also actually great for venous outflow tract obstruction and delays in venous outflow as well. So below the skull base, it can be pretty useful. We personally don't use it, but I know it is done in certain institutions. So let's move on to scenario 4. This is a 35-year-old female with recent sinonasal squamous cell carcinoma resection, has new facial numbness and diplopia, evaluate for perineural spread.
Yeah, I'll take this scenario. Even without the history of sinonasal squamous cell carcinoma, I think if you have a history of facial numbness and diplopia, you want to make sure that your imaging protocol includes enough coverage of the face to image the entire extent of the trigeminal nerve branches. And in this case, we have a history of sinonasal squamous cell carcinoma, so we have a good idea of where it's going to be coming from. But there are other cases where patients present with a numb chin or a numb lower lip. In those cases, you want to make sure that your scan range goes down to the entirety of the mandible in case you have a mandibular metastasis or leukemia or lymphoma and affecting the mandible. If you just concentrate on the intracranial portion of the trigeminal nerve and the skull base, you may inadvertently omit where the pathology is, which is actually located in the mandible, for instance. In this scenario, because we're concentrating on the sinonasal region, most protocols dedicated to the trigeminal nerve evaluation or at the skull base is going to cover the relevant anatomy here. So that's less of a concern. But in terms of the sequences that are most useful for this evaluation, in terms of evaluating for perineural tumor spread, the T1 post-contrast images I like with fat suppression are going to be your highest yield sequences to cover. We like doing a 3D vibe because that's 3D, it's high resolution, allows us to apply fat suppression, and that highlights the thickened and enhancing nerves quite well against the surrounding fat that's located in the skull base region, like the pterygopalatine fossa and so forth. And while that's the most high yield sequence, that doesn't mean you don't use the other sequences at all. I do like using the T1 pre-contrast without fat suppression a lot as well, because fat is your friend, and skull base fat, especially at the pterygopalatine fossa, is your friend as well. So looking for effacement of that fat can be quite helpful in these cases where especially if there's post-surgical changes, a lot that could be causing inflammation on a chronic basis there that might be confusing with tumor. You want to use your T1 pre as well to see if there's any unexpected fat effacement, fat infiltration compared to your prior studies very diligently.
Yeah, I agree. We do the same. We do the 3D vibe post contrast with fat suppression. And as you said, the T1s I think are really important, but that clinical history is diplopia plus facial pain or facial numbness, you're automatically going, we've got to really look at the cavernous sinus, got to look at the, superior and inferior orbital fissures, really check where potentially you're going to get both, involvement of the cranial nerves to the orbit as well as the face. And the other thing I am really diligent about now with my clinicians is really locking down that history in terms of, you've just given me a history of facial symptoms, but exactly where is that numbness? Like which branch is it in? Where do you want me to target? So, obviously in this case, we're presuming it's going to be mid-face numbness given the sinonasal SCC. But as you said, Francis, it's important to know, is it something down on the chin and therefore we need to cover the inferior alveolar nerve as well?
Yeah, absolutely. I mean, we do the same. I pretty much love the T1 pre-contrast as well as T1 post-contrast with fat sat. I guess the only thing I would really add, there was already a great discussion, but sometimes I find useful, not necessarily specific for like perineural spread, but any type of like nerve compromise. You can also look for like end organ compromise, for example, like if the muscles of mastication look like they have denervation changes, something like that, then you might want to focus on, like the trigeminal nerve, for example. But again, that's not going to be specific. That's any type of damage or injury to the nerve itself can cause those kind of end organ edema and enhancement, denervation changes. And then also sometimes, particularly with the cavernous sinus, when you're dealing with a bunch of nerves in close proximity to each other, you can have pathology in one nerve, and just because of mass effect on an adjacent nerve, not necessarily directly affecting that nerve, you can get kind of the end organ compromise as well. So that'll be another thing to worry about. Some key sequences again to summarize. We all love the T1 pre-contrast. It's really great for looking at the infiltration of those fat planes, and particularly at the skull base, pterygopalatine palatine fossa, those neuroforamen and stuff like that. It's excellent. And then the T1 post-contrast with fat saturation to look, essentially for the pathologic enhancement and the thickening of those nerves along their pathways. That you want to do with fat saturation, right? Because like the contrast is going to be bright, and it's going to be T1 bright as well as the fat. So you want to knock out that fat to just kind of increase the conspicuity of the pathologic enhancement. And then another great thing we guys mentioned was just the field of view, the coverage. You want to make sure it's specific to kind of what the symptoms are located at, or if there's like, if the lesion happens to be in like the gingival buccal sulcus, or like, the oral cavity versus, the eyebrow, do you want to tailor your protocols, your field of view to kind of make sure you include those portions of the nerves. So we'll move on to our last scenario, scenario 5. This is a 28-year-old male with spontaneous CSF rhinorrhea following minor head injury, no prior sinus surgery, evaluate for CSF leak.
Again, CT and MR are going to be complementary in this case. I probably would start with a really nice high-resolution CT on bone windows, really, scrutinizing that skull base to try and work out exactly where the site of, presumed CSF leak is, probably the anterior cranial fossa in this case. But it's important not to forget about, the tegmen tympani and the middle ear. So occasionally you can get rhinorrhea from a CSF leak from the ear as well. So, really checking the mastoid air cells and the middle ear cavity to see if there's any fluid there, obviously looking throughout the sinuses. And then when you've sort of found that suspected site of CSF leak, then we also would do an MR as well, and really a heavily T2 weighted sequence, volumetric, so that you can reconstruct it in all planes, and really trying to find that site of CSF leak. And I think the benefit of MR is looking for an associated meningocele with that. So the surgeons really need to know if they're going to be going in and repairing that, whether they're going to come up with a meningocele sitting there.
I completely agree. I would start with the CT, look for bony dehiscence. And the thing with CT, though, is that it's quite good for the bony anatomy, but you may see a lobulation of tissue there. You're not sure that if that's a mucus retention cyst or that's a cephalocele. And so that's where MRI really comes in and shines, because the surgeon will want to know, are they dealing with a meningocele? Are they dealing with encephalocele, right? Are they going to need to cauterize some brain in order to fix this defect or such? So that's important for surgical planning, absolutely.
We also start with CT first, typically either sinus if it's like rhinorrhea, though, or temporal bone if it's like tends to be more, suspected middle ear pathology, or ear pathology, I should say, mastoid temporal bone. The only thing I would say is those bones, it could be tough on CT, like you mentioned. So they are, again, complementary. Like CT, those bones are so thin that even in normal patients without leaks, sometimes they can look like they're thin or dehisced. So I'm generally just a little cautious with my wording. I don't get like overly confident on just the CT. If I don't have any other prior imaging saying something is like definitely a leak, I might say like, I kind of try and point to certain areas which I think are high risk or might be potential sites. For example, if I see the cribriform plate looks like it's thinned or dehisced, I'll say something like that, like thinning or dehiscence at the cribriform plate. I'm not going to say like, definitely a CSF leak there unless it's very obvious, like it's a huge defect and, we can see like clearly, brain coming out or something. But like for the most part, I'm usually pretty conservative on it. I'll try and hone the surgeon into where I think the leak might be coming from, point out certain areas that are dehiscent, and then kind of also so they can pay attention on endoscopy as well as, really look closely on the MRI. Another thing, like you mentioned, Francis, on CT, you see opacification, but you don't know, is that a meningocele, is it a retention cyst, for example. The MRI in that case is also super helpful because like sometimes you can see like an opacified ethmoid air cell, for example, and then you get the MRI and it's very clearly like T1 bright or something, and it's probably just like old inspissated secretions rather than kind of like fresh CSF that's coming out too from the leak. So that can be helpful as well. And then, totally agree, the heavily T2 weighted sequences. I like coronal plane probably best on those thin high-res T2 sequences. Looking at the cribriform plate, other check areas too, like infralateral recess of the sphenoid sinus, middle cranial fossa, those arachnoid pits, and then definitely like the tegmen tympani, mastoid tympani, and stuff for the mastoid temporal bone as well.
Yeah, some of these cases can be challenging. It's really a combination of clinical factors and the imaging before you can really both diagnose a CSF leak as well as to localize the site of CSF leak. So the clinicians will, ask the patient to collect their rhinorrhea in a tube and send that off for beta transferrin. If it's positive, then it's very likely that this is CSF. If it's negative, though, there is a limited sensitivity for this test, and they still may need to keep a high level of clinical suspicion that this is CSF coming out of their nose instead of vasomotor rhinitis or something like that. And then once you made the diagnosis that this is CSF coming out, we can only point to some areas where the bone is thin, possibly dehiscent there. And it may still come down to their judgment in terms of where to look for that CSF leak. And to confirm any site, there are adjunctive techniques to do that. You could intraoperatively inject intrathecal fluorescein and kind of visualize, try to identify a leak intraoperatively under direct visualization. You could inject a radio tracer intrathecally, and the ENTs will pack the sides of the nose, each side of the nose, with some absorbent packing, and then you can kind of see which one of those turns radioactive after a little bit, and that helps lateralize the side of your CSF leak, as well as they can tell what's posterior and what's anterior and so forth. So many different tricks in the toolbox. Potentially, some of these cases can be difficult, and the cross-sectional imaging is just one part of it.
I like recommending the beta-2 transferrin as well, or at least look for that prior to any case that I'm reading. I'll definitely check for that piece of history, see if it's been sent and if it was positive or not. And if they haven't sent it, I typically try and recommend that as well. But generally speaking, the ENT surgeons are aware of that, fortunately, so they're able to kind of, it's usually already done by the time I start reading the cases. But just to kind of sum this up, complementary CT and MRI is going to be, they're going to be great for adjunctive together. And then the thin slice, heavily T2 weighted, high resolution images. Personally, I like the coronal plane, but you want to do it volumetric so you can kind of reconstruct it in any which way, which can be helpful for picking out CSF leaks. And then CT sinus or temporal bone, looking for a bony defect, depending on where kind of most suspicious. So some teaching points: look for that anterior skull base defect, kind of more case specific here, which can be common areas include cribriform plate, sphenosinus infralateral recess, arachnoid pits in the middle cranial fall. So that's a particularly important one for patients with idiopathic intracranial hypertension. They may have a lot of those under high pressure. And then mastoid temporal bone is also a common location as well. And you want to assess for associated meningocele or encephalocele, which is obviously going to be very important to know preoperatively. And then, we like to recommend beta-2 transferrin if it's not already obtained. Well, I think it's a good time to draw our discussion to a close. So thank you both for joining me and for all those pearls. It's all going to be so helpful for the audience and also me. So thank you to you both.
Thank you, Dan.
Thanks, Jen. Thanks, Francis.
Thank you to Dan Gewolb, Jennifer Gillespie, and Francis Deng for recording that panel discussion there. And each of them will be back in some capacity, Gaylard, for Radiopedia 2026 this July, especially Dan, who is one of the conveners this year, and he's recording multiple lectures, panels, and workshops. He basically says yes to anything. He's a yes man.
He's a yes man. That's great. When he was speaking about how he approaches protocoling the studies, digging around in the EMR for clues, it reminded me of a saying that one of my mentors in Vancouver, Raju Haran, had, which was cheat to win, by which he meant, or at least I think he meant, that the answer is not always in the images. And if you go snooping around in the EMR, you can add a lot more as a radiologist and you can get the correct answer and look really smart, but actually the answer is somewhere else in the patient record. Anyway, did you have anything you wanted to discuss about that main segment, Dixon?
It all comes back to the Dungeon and Dragon axis there with the cheat to win as well. I've written down a couple of things, Gaylard. So I take the infectious diseases meeting each week at my hospital, well, at least the weeks that I'm around. And skull-base osteomyelitis follow-up definitely comes up as a question from time to time. And I think it is important to be aware that the imaging findings very much lag behind the clinical recovery. And sometimes the question, you get asked is there still infection? And it's probably not a great one to be answering on MRI. Obviously, if it's getting a lot worse and there's collections and things like that, you can answer that question and it's good for looking for complications. But if it looks similar to the previous one, that's not necessarily a sign that infection is still going on. The treatment may be working. Definitely gallium scan is something that comes up in our meetings from time to time as well. You know, the more experienced infectious disease physicians will be like, we should get a gallium scan for this patient, because I think that they know that is actually often more helpful for them to know whether there's active infection.
Yeah, that's a really important point. In many situations, imaging features really do take a long time to improve. In the brain, medically treated abscesses, for example, can look worse for some time, even if they are, being successfully managed with antibiotics. Fortunately, in the setting of a cerebral abscess, you've got ADC values to look at, and increasing ADC values, even if the rest of the lesion looks worse, bigger, more edema, thicker rind, is the thing to look for helpful management. But in the base of skull, it's such a mess down there that you're not going to be able to really measure ADC values reliably. Yeah, so it's hard. And you can do harm by reporting studies as increasing infection or persistent, because it might mean changes in management, etc. So part of the secret is to not go looking. And,
not do the scan. Exactly. Yeah. So delay that scan. Often if they're clinically well, you'd be like, well, there's no reason to scan at this point. Let's delay it. And or if they get any symptoms, then we can do a scan. But it's certainly one of those ones where you kind of trap yourself by doing the scan too early, and then you're like, well, it still looks pretty bad.
Yep.
Anyway, so another thing I've written down here was with the pulsatile tinnitus discussion. And I think it kind of came up in Dan's case set itself, but not so much in the panel discussion that we've just played here. And that is not to forget about idiopathic intracranial hypertension as a cause. I think it's probably the number one cause that we see these days, and it can definitely be missed on imaging if you aren't thinking about it. So if you're doing a pulsatile tinnitus scan and you've got an MR, look for those classic signs of intracranial hypertension.
Yes, that's an excellent point. In fact, intracranial hypertension is a condition that can present in so many ways and is so often overlooked that it should really be a little bit of a mental check area for many of your scans.
Yeah, particularly if you've got a young to middle-aged female patient in particular, or if they're overweight as well, that should really be something that you should be looking quite specifically for. I've also written down here that quote from Francis, which was from one of his colleagues, I think, an abdominal radiologist. My favorite MRI sequences is the CT. It's so true. So true. As an aside, one thing I like to do to annoy my sonographers, anytime they bring me an ultrasound scan to review, if there's a previous CT, I always start by just looking at the CT, and you kind of like, they're like, oh, there's a cyst, blah, 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 and you just look at the CT and you're like, yeah, there's a cyst. Yeah, there's a thing. Yeah, there's a thing. And they're like, yeah, that's all I saw. And you're like, okay, good. It's like they've done this, spent half an hour scanning a patient on ultrasound, and I've just been, I saw all that on the CT. Anyway.
Yes, no, CT is great. And especially when it comes to anything calcified. I've been wanting to do a talk at some point on calcification of brain conditions on MRI, because you can sometimes hide the most florid calcification on MR that is so obvious on CT. And the other thing that can be really hard on MR are craniotomies and treated aneurysms, where coils can be really difficult to see, or even a big craniotomy can be really difficult to see, whereas on CT, they all stand out very, very, very prominently. And the temptation is not to bring up a CT brain when you're looking at MR, because you think that there's nothing that you can see there that isn't better seen on MR, but that's absolutely not true.
Yeah. I also wrote down here, skull base CSF leak. Gaylard will definitely want to mention the difference in imaging signs between a spinal CSF leak, which has all those low pressure kind of signs in the head, versus a skull base leak where you don't necessarily get those signs.
Oh, you know me well, Dixon. It's like we've been married now. You can preempt everything that I'm going to say. But that is a really important point, and I think one that is misunderstood or not understood really commonly. And that is that if you see hypotensive features on a cranial MRI, so thickened pachymeninges, engorged dural veins, and prominent pituitary gland, etc., then the cause is not in the brain. The cause has to be lower down, typically below mid-cervical spine. And the reason for that, it's complicated. I don't think I fully understand it. but it's the interplay between hydrostatic pressure of CSF, so that when you're standing, the column of CSF increases the pressure of the subarachnoid space at each place, so that's highest in the lumbar region. But combined with the changes in venous drainage, so that when you're standing, the dural venous sinuses are kept open because the dura is fairly rigid, and blood is literally falling down your jugular veins and sucking the blood out. Whereas when you lie down, the veins sort of fill up and provide some extra pressure. But the combination of those two things is that the only time that you get a proper negative pressure intracranially is if CSF is continuously being pushed out by positive pressure in the subarachnoid space. And that only occurs lower down. And it can either be pushed out into the epidural space or along a nerve sheath, but increasingly recognized as CSF venous fistulas. And the reason that's really important to understand is that if you go hunting for a cranial cause of a CSF leak when you've got signs of intracranial hypotension, one, you're not going to find it. But two, just because you're not seeing an epidural CSF leak doesn't mean there's not a CSF venous fistula. And that's a really important diagnosis. One, because it needs to be treated, but also because a significant proportion of these patients will go on to get superficial siderosis, which is irreversible. And so they'll become deaf and they'll get cranial nerve palsies, etc. So it's a really important diagnosis to think of. But the way that you image a patient with CSF leak from the nose or the ear really is very different, and you shouldn't be looking for those hypotensive signs. In those patients, you really have to look for the leak by doing high-resolution base of skull imaging, etc.
And of course, we have a lot of veterinary listeners, so we just need to say that this doesn't apply to bats. Presumably flip it around. So if you are looking...
Yeah, you're looking for thickening of the thecal cul-de-sac for craniospinal
it would expand up. You get these big subdural hygromas in the lumbar spine.
And what about overweight, middle-aged female bats? Do they get intracranial hypertension?
It's a very good question. I mean, we do have a lot of veterinary radiology listeners, so it would be nice to get someone to write in. I'm sure there must be a paper on lumbar spinal hypotension in the inverted bat species. Anyway, that's all I had written down on my list here, Gaylard. Have you got anything else to talk about?
Well, I do believe that bats actually get tuberculosis in their lung bases. I think that's a thing.
It sounds like
because it's microaerophilic mycobacterium, right? And so the lung bases would... Anyway, I'm pretty sure that's a thing. I don't think I've made that up. But I did have a couple of quick things.
That's a list for next week's episode to look up, or next month.
I had a couple of quick things from the main segment. The first thing is Francis talked about fusing MRA and KISS for trigeminal neuralgia. And
no, we don't do that at my hospital. Do you have that?
So we can do it. I do it almost every case. I do find it is kind of useful, particularly where the KISS is busy and there's a lot of veins and other stuff, and you're trying to sort out which is an artery and which is a vein, and it can be a little bit tricky sometimes to really sort it out, and it certainly helps. But what I've started using it for increasingly is in MS patients to look for the central vein sign, where you fuse flare and susceptibility weighted imaging, because SWI doesn't show the plaques that well, and flare doesn't show the central vein that well, but fusing them together, you get this beautiful black vein going through a bright lesion. And we do both flare and SWI as volumetric studies, so you can even reconstruct the fusion to show that it's running right through the middle of the lesion.
The central vein's only relevant really in the very first scan to make the diagnosis, right? Because it's kind of like dissemination in time, essentially.
Yeah, and we don't do susceptibility weighted imaging on follow-up imaging. We just do it on first presentation or query MS studies, because it's just, there's not much point for it.
But this is a discussion for another time, Galo, because for the conference, you and I are doing a discussion on MS.
Yes, so you've told
criteria
me.
For that.
So you've told me.
So I've told you.
The other comment I had was about trigeminal neuralgia, and I think it's really important to think about this, and that is the point of an MR for trigeminal neuralgia is not just to look for an impinging artery. In fact, you can make the argument that the biggest thing that the MR for someone who has trigeminal neuralgia is to exclude other non-vascular causes. And so that does impact your your protocol, because otherwise you could kind of get away with just doing a KISS and an MRI. But you really do want to image the brainstem and want to give contrast, because multiple sclerosis particularly, but any other kind of brainstem lesion can cause trigeminal neuralgia, and clearly that will be refractory to surgical management. But importantly, if you don't see a vessel and you don't see any other cause, and the patient has good clinical trigeminal neuralgia, surgery is still effective in a large proportion of those patients. And when they go in, they will find a very small vessel that you can't image. So to really focus a lot of your attention on finding all the other possible causes for trigeminal pain.
Yeah. And the other thing is, and I think they mentioned it, covered in the perineural tumor section of that discussion as well, is that, trigeminal neuralgia, is it actually trigeminal neuralgia? If there's any kind of, facial numbness or anything else associated with it, then that's really a cranial neuropathy, and you're really looking for a cause like, head and neck cancers spreading along nerves. So you really want to be having a look at those base of skull T1s, look in the pterygopalatine fossa, etc., for anything else that's going on. Anything else?
Just a quick update. Back in 2023, episode 20, would you believe?
Oh, the good old days.
The good old days. I recorded an interview with Brian Tress, who
the good old days where Frank recorded interviews. Remember those times?
That's right. I remember those times. Anyway, I recorded an interview with Brian Tress, who was the head of the Royal Melbourne Hospital Radiology Department when I started training. And in that interview, he talked about what it was like to train as a radiologist in the 1970s. Anyway, he was just made an Officer of the Order of Australia, which for inexplicable reasons, the acronym is not OA, but AO. I guess to confuse with the Australian Open. That's running
it's
at the
a tennis thing.
So he was recognised in 2026 Australia Day Honours List for his distinguished service to neuroradiology medicine, to interventional and diagnostic radiography, which is a bit annoying, and to the introduction of a new imaging technologies in Australia. It's a very well-deserved honour, so well done, Brian.
How do you like to celebrate your Australia Day, Gaylord? Are you whack an Australian flag out the car, or put it on your back like a cape, go down to the beach, look for a bit of a fight?
Get another tattoo of the Australian flag somewhere on my body.
Another one.
I celebrated
one that just says Straya.
Straya.
S-T-R-A.
I celebrated it by being at work all day, actually, which was as much fun as it sounds. Yeah.
Anyway, it might be time to wrap this episode up. Gaylord, how can people get in contact with us?
Well, you can email us at podcast@radiopedia.org with any ideas and or feedback, particularly if you're a vet and you have any inverted animal-related feedback.
Or an expert on Mycobacterium tuberculosis as well.
What do you think an expert in bats is called? There must be a word, right?
Batty.
And you can, of course, join the Radiopedia community chat by visiting radiopedia.org/community.
Yes. So speaking of emails, you can write to us just like Sadaf, who writes, and this is a long email, but a lovely email. So I'm going to read most of it out here, Gaylord. It reads, Dear Dr. Dixon and Dr. Gaylord, wishing you a very happy new year. Your recent Radiopedia podcast on career journeys in radiology resonated deeply with my current situation. I am finally returning to clinical radiology after a long career gap of almost 5 years. I completed my training in my home country and also obtained a fellowship there. Belonging to a low-income country, I was the first radiologist at my hospital to be granted a free all-access pass to Radiopedia, and I subsequently encouraged many of my colleagues to subscribe as well. I'm now a gold-level supporter of the website. That's the very least I can do. 5 years ago, I moved abroad due to my husband's job, where my training and qualifications were not recognised, and the pathway into radiology training as an international medical graduate was unclear. This sounds like a scenario very common for a lot of people in Australia, or coming to Australia as well. As a result, I became a stay-at-home mum. During the period of raising young children, I began my journey towards FRCR. Quite honestly, had it not been for Radiopedia, I would never have completed it. I appreciate that nothing can replace hands-on clinical experience, but I wanted you to know that I passed my FRCR modules on my first attempts entirely supported by Radiopedia. I remain deeply grateful for the quality and accessibility of the material you provide. I have recently received a job offer to work as a radiologist, and while I am excited, I am anxious. I wonder whether I will be judged for my career gap. They did hire me fully aware of this gap, so I remain hopeful. I have not missed any of your virtual conferences since 2020. I'm actually grateful to the pandemic for making them virtually accessible. You both feel like family to me from afar. I hope that when I'm experienced enough, I might be able to contribute to your conference and perhaps even meet you in person one day. Thank you once again for everything you do for the global radiology community. Warm regards, Sadaf.
That is a lovely email. Thank you, Sadaf. I never get tired of hearing from people who found Radiopedia useful and love meeting folk at different conferences. Actually, this year, Dixon, I've got a bit of a full calendar.
And you've said yes to a lot of things.
I've said yes to a lot of things.
You're the yes
which
man.
I think future Frank is going to be very upset at past Frank for having said yes. But I will be at ESNR in London this year and also at ASNR in Austin, Texas, and soon at ANZ SNR.
Yeah. I'll be at that
Gold
one because
Coast.
that just involves me going on a plane for a few hours. That's it.
Right. So hopefully I get to catch up with lots of people along the way.
One day I have visions one day, Gaylord. Probably once our children have towards the end of high school or finished high school, where we could go on tour or something. We should have
T-shirt with tour dates on the back.
Well, I think T-shirt we could do now, mate. The T-shirts are easy. We can just wear those. We should talk one day about Taco and Horror Night as well, because we need to get T-shirts for that. Anyway, I'll save that for another time. I've got to read this next little bit. So if you want to help support radiology education for people in low and middle income countries, just like Sadaf, then you can become a paid supporter on the website, or you can purchase an all-access pass to our online courses and conference. So we rely on paid pass holders, obviously, to keep things free in 125 middle income countries, to allow people to get access to this information so they can pass exams and find work in different countries or whatever they want to do for their career journey. And what else can people do to help us out, Frank? I just ad-libbed that. Sorry.
And, well, other people. What? And, well, other than becoming supporters, you can also help us out. But I don't know. I don't think that makes any sense now.
No, it doesn't make sense because I think this is from a prior episode. We haven't deleted. Hang on, let me just.
I think you should leave all of this in to really show it under the hood.
Other than become supporters,
I know.
You can help out.
How about did that on purpose?
You can also help us out.
You can
like that. Hang on, let me do this line because this is my daughter's favorite line. She never listens to anything, but if she hears this, she just wants to hear this bit. And what else can people do to help us out, Frank?
You can also leave a 5-star review in the podcast app of your choosing.
Yeah, that's the line. That's
the
it.
one.
So when we copy this across to the next episode, the line will be correct rather than.
And it's important that you can choose the podcast app. We don't mind. Whichever one.
No, we don't mind. Yeah. There's literally probably 2 that people use, though, looking at the stats. So leave us. And I don't even think you can leave reviews in Spotify. You can just give us 5 stars. But Apple, you can definitely type words in. But I think people find it hard. It's too hard.
It's too difficult.
You want to put your name on things these days. Once, I don't know if I told you this, but once my wife put a comment on some podcast or something, but it came up as my name rather than her, just because in Apple it must be called Andrew Dixon. And then she didn't know how to delete it. So I just had this comment that did not reflect what I thought about it.
Well, anyway, the other thing that's related to that is Google Maps. If you leave any reviews, it has your real name attached to them. So much for any anonymity about where you live. If you start leaving reviews around, it's going to be very easy to triangulate.
That's not bad for one of those murder mystery kind of drama things when they're mapping it out and they're like, he probably lives in this, the murderer probably lives in this area because he's left reviews at this place, and then they triangulate in on where.
Yeah, and he likes those noodles, so we'll stalk him out at lunchtime.
He's always at this ramen bar. Anyway, we'll leave it there and we'll catch you all again sometime soon in the reading room.
Stay rad, everyone, and catch you at all the different SNRs around the place.
If there's a neuroradiology meeting, there's a Gaylord there. All right, see ya.
Bye-bye.